All right, great. Okay, so I am right now I have the pleasure of introducing Dr. Nabil Abou Baker. And Dr. Baker is an associate professor at the Med-Peds Department at University of Chicago. And we actually met at ACGME meeting at the Disability Summit. And I was like, oh, wow, I was really impressed with all the stuff that he's done. And he is also mentoring one of our former summer interns, Dr. Zoe Sheets. And so we've already had a lot of great discussions at the summit. And obviously, we are very passionate about making sure that we have disability health training for students, residents, fellows. And so I thought this would be really wonderful to have Dr. Abou Baker join us and learn a little bit about what he's doing with residents, which is an area that we still need to expand on. And so I want to just provide a little bit of background. So he's an associate professor at the Medicine-Pediatrics at University of Chicago. And he also was here at, not necessarily University of Michigan, but he is at the state of Michigan for his medical school with Michigan State University College of Medicine and attended Med-Peds residency at Rutgers University in New Jersey Medical School, where he was a chief resident as well. And Dr. Abou Baker has been at the University of Chicago since 2017 and serves as the director of the Med-Peds PATHways Transitions Program and associate director of the Med-Peds Residency Program. And he is also the co-chair of the Transitions Committee for the Med-Peds Program Directors Association nationwide. And regionally sits on the Illinois Healthcare Transitions Collaborative and helps to plan the statewide annual Healthcare Transition Conference, which will be held in Springfield, Illinois, on October 30 and 31. And we're happy to share that information later. So, yeah, thank you so much. So I'll turn that over to you. And I want to make sure you're able to share and advance your slides.
Yep. You should be able to see a PowerPoint slideshow right now. Can you guys see it?
Yeah, we can. You may want to put it on, yeah, put it in the slideshow. We can see your notes.
Oh, you can see my notes. Okay,
Yeah, you may want to get it into full screen.
there you go. Can you see
Yeah,
the?
perfect.
Okay, perfect. All right. Thank you so much. Sorry for being a little tardy. I appreciate everyone's patience. I'm going to be talking about the Med-Peds Pathways program here at University of Chicago. I'm going to be focusing mostly on residents, but if you have a question about medical students, more than happy to answer that. I have nothing to disclose. No one pays me for this except the university. So I don't have any big pharma money or insurance company money. Some of the things I'm going to discuss are listing my interpretation of the three pillars of healthcare transitions, at least the way it is here. Hopefully getting everyone to understand holistic evaluation of adolescence and discussing our didactic and experiential care model for education. Um, in the event you guys don't know, healthcare transitions is a planned and purposeful movement from the child to a child model of care to adult-centered care. This is as opposed to the other different types of transitions, which are like inpatient medicine to outpatient medicine. Though those are extremely important, it's a different flavor of transitions. This is a really important topic in people's lives because they're going through a lot of transitions. As we age, we go from early childhood to middle childhood to adolescence to adult. And then as adults, we transition ourselves, whether we're changing homes or communities. We may have transitions of healthcare providers. And depending on education model, we go from middle school to high school to college for some people. So there's a lot of transitions in people's lives. And as people move from adolescence to adulthood, a lot of these transitions meet at a certain point, at an intersect there at that age. Now, my purview of age is somewhere between, I will consider transition somewhere as early as 12 and as late as 26 to 30 as adolescents and young adults. So I have a holistic age range there. I will see anybody from age a newborn to 99, 100. I don't think we have anyone in our clinic that old, but I'm more than happy to take care of geriatric patients. Now, it is important to keep in mind this becomes more challenging. A transition if you have a developmental disability, for example, or an intellectual disability, or a chronic medical condition. So depending on the condition and what is surrounding the patient, the complexity of this movement, increases. And it can increase quite profoundly depending on the number of complications that has occurred in this young individual's life. Now, why do we need it? Somewhere between 500,000 to 750,000 in the United States with special healthcare needs graduate to adulthood. And the youth with special healthcare needs, that's what that abbreviation stands for, account for 13, maybe 15% of youth, but somewhere between 50 to 75% of medical expenditures. So it's costly to the medical system. But it's important that many of these individuals will reach adulthood, and they may have a significant or severe disabilities. Back in the 80s and 90s, they may not have reached adulthood. For example, the majority of patients with congenital heart disease are adults. Patients with spina bifida commonly reach adulthood. Patients with sickle cell disease and cystic fibrosis are living into their 40s and 50s, when in the 80s, they may have died in childhood. And then a large portion of our population in the United States have intellectual disability, at least 1%. Now, healthcare transitions is a large priority for the country. There's a joint report issued by the A.A.P, American Academy of Pediatrics, AFP, American Academy of Family Practice, and American College of Physicians, ACP, and the Affordable Care Act recognizes transitions as an essential service. Healthy People 2030, for the country, an initiative for the country with public health goals, clearly states there's an importance in transitions, and it's AHR01, and it states as it literally says increase the proportion of adolescents who get support for their transition to adulthood. The majority of children do not receive appropriate healthcare transitions in the United States. Depending on the area, it varies between 50 to 80% of children with special healthcare needs do not receive the appropriate transitions. And if you look at children without special healthcare needs, that number is even higher. So we do have a paucity of providers who can give this type of care to patients across the country. Now, healthcare transitions does work, and it works fairly well. It's a very challenging thing to study because of the variance of model of care delivery throughout the United States and insurance. But when you look at specific disease entities, we have been able to show that there's improved adherence to care, there's improved perceived health status, quality of life, and self-care skills. Several years ago, I worked on a paper regarding quality of life in patients who have good transitions of care service. It correlated quite well with higher quality of life. They have increased adult visit attendance. They have a shorter time between their last pediatric visit and their first adult visit, which is fantastic. And then looking at the healthcare system, there is decreased hospitalization rates, whether that's ICUs, ED visits, and admissions, and does yield cost savings, especially when looking at the medical home model. where people can get wraparound services and hopefully services that include um, primary care, but also subspecialty care, physical therapy, occupational therapy, speech therapy, um, mental health and behavioral therapy as well. And I can't stress this enough, significant help with case management and social work. Because a lot of the things in my system span around being able to navigate the health system. So the Med-Peds Pathways at University of Chicago, its pathway stands for Program for Adolescent and Young Adult Transition to Health. We care for adolescents or young adults transitioning from the pediatric model to the adult model of care. And I'm gonna talk a little bit about the clinical service. That's what the majority of my stuff will be on. We'll talk about education, but understand that clinical service and education go hand in hand, and scholarship. We do have a website, transitioncare.uchicago.edu. I need to make some updates. There's some older stuff there. I haven't had a chance to update it in a couple of years. But that's where a lot of people will go to get a little bit of information for our services. Oh, that's a picture of our website. So a little bit about clinical service. So the main one I'm going to talk about is inpatient consult service model, because it's different than many other places. So we get consults from both pediatrics and adult medicine, so from both sides, for admitted patients with varying medical condition or disabilities. So examples of the most common consults we receive are developmental and intellectual disability, cerebral palsy, type 1 diabetes, seizure disorder, lupus, that's what SLE is, sickle cell disease, chronic kidney disease, and renal transplant, chronic lung disease, with use of a ventilator, dysphagia with use of gastrointestinal tube for nutrition. Someone will be admitted, for example, to the adult service. They're over the age of 18, for example. They may be in a disease crisis or medical condition crisis where they need help from that admission to help stabilize them. Then they'll bring us on board, and we'll make an assessment. We'll perform an assessment to help guide them. The most common reason, those are the most common medical conditions we get consulted for. The most common reason we get consulted for are challenges in finding providers and navigating the healthcare system. So that could be insurance status, that could be family dynamics and community, finding social support for the patient, as well as being able to give them support if they need anything for specific medical conditions. Now, many other places have, as well as us, have outpatient consults that runs of one of the subspecialists or a pediatrician may consult us, or an internist may consult us. They'll put in an order and we'll see them in our clinic with the residents. The residents do get as in the inpatient as well as the outpatient, they get to see the patient and they do holistic assessment, and I precept with them where we help address the situation. So I have a residence. There's 13 blocks an academic year. Each block at University of Chicago is 4 weeks long. And I have a resident on call for the service every single block of the year. I have no resident coverage on the December holiday block. In the event you're wondering how this runs. And when the patient's admitted, the primary service will page us. The resident will do the first pass assessment, which we'll discuss in a little bit. And then they'll present to me and we'll work together to meet the needs of the patient. So if anyone has any questions, by all means, you're more than welcome to interrupt me, or you can leave it for the end. Yeah, go ahead.
Dr. Abou Baker, this is Mike. So in terms of this consult model, I know we chatted a little bit, but I think this would certainly be of interest for everybody. It's figuring out how to support and also get buy-in from medical schools, residency, and hospitals to support something like this. I was just curious, given the different common consults that you tend to cover, some of them are more chronic illnesses, but many of them do have ongoing long-term disabilities. Were you able to get buy-in because of did you approach it where it was more of a disability approach, or was it more chronic illnesses, but disability being a part of it? Just how were you able to approach it, negotiate, and support this?
Good question. I would say the hardest thing was getting buy-in from the administration to get time buyout. The residents are really passionate about this, especially my residents here. So for them, I think they were really fired up in the past to get this going, and we've had this service for years now. So every future resident knows about this. The buy-in took, I didn't talk about this in the slide, but I'm more than happy to answer this question. The buy-in took a couple of things. It was showing the number of patients that were being admitted that could have been prevented, and thus developed a cost savings. So how much we're using our medical system inefficiently. So there were numbers associated with the buyout. In addition to the revenue generating that would occur from having a consult service. None of our consults have been denied by insurance for reimbursement, despite it being like, I'm a board certified pediatrician and internist. So like a general pediatrician will consult me, and I will reply to the consult as an internist, and as an internist, I can reply to the consult as a pediatrician. So being of two different departments allows me to flip back and forth relatively easily, so I don't have a barrier of billing. So the work that I do does generate clinical RVUs. But I think from the resident standpoint, they get a lot of hands-on learning that I'll discuss in a little bit, because I think the model that we have set up has the ability for people to understand the importance of navigating our system, or at least the healthcare system here in Chicago, to help best support the patient. I can't, for example, guarantee, so I don't try to anchor it on the condition, because I can't guarantee that they're going to see the same condition again, especially when they leave or in medical practice. Like if we're consulting on an esoteric metabolic syndrome, I'll give you like a uric acid cycle defect. We don't have a metabolic geneticist here. And so I may help them work through those things, but the idea is that they need to learn about the medical condition. I'm not denying that, but I want them to make sure that they understand how to get services for the patients, how to meet them where they are, how to assess for the disabilities that they have, so that the next time they have a patient with a chronic condition, disability, they're able to translate those skills across the continuum for the residents. I hope that helps answer your question, but like I think the hardest buy-in is from the administration, proving this is financially viable. And like I can't stress enough how large cost savings this is for the medical system, especially for patients who are part of the accountable care organization, and we have cost sharing agreements with the insurance companies that allow us to get additional services to prevent less than ideal use of the emergency department, ICU, and inpatient hospitalizations. And like the biggest example I can give, the easiest basic example I can give is like, imagine someone with type 1 diabetes that didn't get appropriate services, that just straight up ran out of insulin and then went into DKA, diabetic ketoacidosis, and then went to the hospital and need to get admitted to the ICU, all because we didn't get a refill of the medicine. That's something extremely simple that ended up costing the medical system and the university actually a lot of money. And so when I looked at specific conditions, I saw that there was actually a large burden of money, and a high readmission rate that we could work together to target and bring down. And over the last several years, we've brought down our admission rates on now each condition will need a very specific tailored approach because each one is different. But we've been able to demonstrate like large drops in admissions throughout the years when I compare from 2018 to now post-pandemic. Some of which is confounded with the pandemic. However, I think it's being able to provide better care for patients is ultimately what it boils down to.
Yeah, that's certainly impressive. Thank you for the answer. And I put just a couple of questions. You already addressed one of them. But I also, if others have questions, please feel free to speak up. Yeah, don't be shy. Dr. Abou Baker has really a lot of insights on this topic. It's a challenging topic. Any other questions before we allow him to move on?
And when you say we, in terms of the consults, what is the breadth of the team involved? Is it just the medical, or is it interdisciplinary?
We don't have, great question. We have a social worker on the inpatient side and outpatient side. We do have pharmacists with us that help us with pharmaceutical medicines to help improve affordability. The residents, sometimes we have medical students, usually about half the year there's a medical student with us. Of course, attending, I mentioned the resident. We will rope in different therapists.
And do you mean therapists? Do you mean psychologists, or do you mean physical therapists or occupational?
Great question. So we'll rope in physical therapists and occupational therapists and speech therapists as we see fit when we need help on the, for example, inpatient service or outpatient service, but we don't have someone permanently in our team fulfilling those roles. We have a relationship with a therapist here at University of Chicago, although they are limited by the insurances as to who they can provide long-term therapy on. So we often have to work with community partners to get people behavioral or mental health resources or providers. But that's a really great question.
Thank you.
Yeah, so how is disability information collected? It should be documented as a chart. If it's not documented chart, the resident usually will ask about different disabilities that the patient has. And how is cost savings measured? It depends on the condition. It's likely a reduction in length of stay, a decrease in readmission rates, and looking at the daily cost saves from previous years, a historical for using the patient as their own control, pre and like post intervention. There are different ways to measure cost savings. I don't know that any way is better than the other. There's probably easier ways, especially if you're looking at large populations. The problem is if you have looking very narrow disability or condition, you may not have enough of a control. So we often will use historical data as their own control, which is fraught with its own problems because some people have compounding complications afterwards that are sometimes unpreventable. Okay. All right, so GOT transitions is a cooperative agreement between the Maternal and Child Health Bureau and National Alliance of Advanced Adolescent Health aimed at improving the transition from peds to adults. And so there's 6 major core elements, and this is like a quality improvement strategy that aligns with clinical report algorithms to help push transitions of care. And so there's pediatric versions and adult versions, and this is all modeled after medical home, and it's developed by the Center for Medical Home Improvement. So the 6 core elements from the pediatric model, this is there is a third model actually for family practice and Med-Peds that I'm not talking about. The reason I'm not talking about it is because this is the reason I get consulted for. There aren't enough of providers who care for patients with disabilities or chronic childhood conditions. We do have an adult developmental disabilities clinic here at University of Chicago, but it is full. It is full beyond full. There are too many patients and not enough providers, essentially. And so from this standpoint, I try to make sure that we can connect people to adult providers who are comfortable caring for that condition and that patient population. And so from the pediatric standpoint, I try to make sure that the pediatricians have a policy, a registry where they track patients, have developed a preparedness for their clinics or the clinical operation, have planned this with the patient and their caregiver, have a transfer of care. So that's the movement of going from the peds to the adult model of care, and then have an assessment afterwards to gauge quality incorporated in transfer completion. And on the adult side, there needs to be discussion of adult privacy and consent policies, creating a young adult registry where they can track people being able to prepare and receiving these patients from the pediatric side, and giving feedback. So in that transition completion, giving feedback to the pediatricians as to what went well and what didn't go well. We, from a third-party standpoint, help this by developing portable health summaries for patients, and they can use that to help a lot of things. Use it for all the way from something to help communicate to other providers as a document of proof for their plan, their emergency plan, for example, in conditions that maybe are less than common, or to help them get services, or to help the providers write letters, whether it's for wheelchairs or DME or other equipment. This is a sample timeline. This timeline in the ages assumes the condition was present prior to the age of 12, right? But if a condition occurs, and where I was at before, like approximately 15% or so of the patients that I worked with transitions were patients who were victims of trauma, and so they had physical disability after trauma, and that can, for example, that can occur at any age. So if it's 16, then we have the same cycle, but it's accelerated. So in that younger adolescence, there should be a policy. They hope they're placed on a registry so we can track how they're going along as they age, assessment of skills, developing a plan, a healthcare transitions plan, and a medical summary. Often there's in patients who have an individualized education plan or going through public school, there's transition services incorporated in their IEP in these schools. But incorporated in, I think, our plans is important to keep in mind what the schools are doing and where we fit in to help support them medically. to be successful as they age through. Go ahead. I see
So
you.
do you bring in voc rehab?
Say that one more time.
Do you bring in vocational rehabilitation in this process, especially given the IEP and given the plans for transition to college or transition to employment and what all this means?
Yeah, so we do talk about vocation and education, and we try to have, open dialogue between the schools, so that we can help support the patient. Yes, we don't.
But do you actually have involvement with the state organization and the counselor from there?
So each school is a little bit different. I do have someone from DSCC, Department of Specialized Children's Services, who I work with on a monthly basis. But they specifically don't assess, that person doesn't specifically assess the patients. If
Okay.
that's your question.
Actually, it wasn't. It was more in terms of another part of the plan, but
Oh, there is vocation services in part of our holistic evaluation. Yes.
okay.
Yeah. There, I'm going to show you the sample one from GOT Transitions, which is the national one that people usually do. And then I'll have my own like little flavor of what we do. And then hopefully somewhere between 18 to 21, there's some discussion about making an appointment in the adult clinic or an adult model and then transferring over, and then eliciting feedback and trying to improve. This assumes a person's going to leave one clinic and go to another. I still do these things in my own clinic, and even though I don't transition patients physically from one location to another, but it's a transition of mindset, to help see if we're developing independence and to check off the items that are important as people age that I'll get to in a little bit. This is a sample healthcare transition readiness assessment. This is from GOT Transitions. It looks at, this one it specifically looks at like healthcare and a little bit of navigation of the system. And it's not as holistic as I'd like. So what we do is slightly different here at the University of Chicago. And where is it? Hold on a sec. Oh, there we go. So my view of transitions is a little bit more holistic than GOT Transitions that focuses mainly on the medical condition and a little bit navigation of the system. So I look at the medical condition or medical disease, the education level, socioeconomic status, any developmental and intellectual disability, insurance, race, ethnicity, the age of the patient. It's a big difference if it's person's 12 versus the person's 17 and going to turn 18 in a week. Sexual health or reproductive health, mental health and behavioral health, and then physical disability. And then I have a question mark there for people that I didn't make a little pie sliver for that aren't, included in this. This is to save space for them and have a more holistic approach. And then this is the individual person. So I don't think I didn't create this. This is essentially the biopsychosocial model of medicine, but this is my interpretation of that through the lens of transition. So this encompasses maybe the individual and a few things outside of them. And then when I grow bigger than them, it's incorporating the medical professionals, be it their primary service team members, their subspecialists, their therapists, their physical therapists, etc. And then the caregivers, the family, the friends, so the people that are surrounding the person that we're trying to help. And then the environment they're in, so their home and their community. If, for example, they have a condition that is impacted by those things, then it's important to know. Okay, and then so these are the things specifically that we address in our transitions of care consults. So we look at chronic condition management, and I'm more than happy to send like I give the residents a little questionnaire of things that they may spur their mind to help talk to the patient about. So little scripts. of how to phrase things or questions they may ask the caregiver or patient. I don't have that in the slides, but I'm more than happy to share that. We have a smart phrase. Our electronic medical record is called Epic. We have a smart phrase where we auto-populate notes. We have a note template that residents can use to discuss these things, as well as provide resources for the patients. Now, the resources we do provide is fairly general. So if there's a specific condition entity, and they tell me about it, I usually will know someone that can help, to provide support for the patient, whether it's a patient support group or a specific social worker through the state that can provide additional resources. So we do chronic condition management, disability services and management. We discuss how race, age, and ethnicity impacts a condition that they have. We try to set people up for success with insurances. So there's a lot of talk about adult Medicaid, pediatric Medicaid, whether we've applied for Medicare. I have a lot of discussion about sexual health. Especially if they have medical conditions that require medicines that are teratogenic. And believe it or not, this happens. People prescribe teratogenic meds all the time with no discussion of sexual health. And, people get pregnant. And it is something that we could have prevented from having discussion, at least an open, honest discussion. And then the flip side is getting treatments that worsen fertility or may render someone infertile, and having discussion about reproductive health in terms of whether it's sperm freezing or egg freezing. And then the last thing regarding sexual health is, like, if there's any conditions that are specifically any discussions about sex or reproduction or libido or masturbation. Those are things that we have, room to discuss in there. We talk about education, vocation, and employment, try to get people services for these various groups, whether they want them or not. Financial planning, there's a lot of discussion about SSI and SSDI. So to help support patients, because having a disability and a chronic condition is not cheap. We do decision-making and guardianship. So if they need help with guardianship paperwork, we provide them with guardianship. We work with our social workers to help complete that paperwork, so that everything is appropriate when they transition to the adult model. And then try to provide resources, I mentioned this one before, for mental and behavioral health, regarding any things that we can tackle. Later this year, for example, I'm giving a talk on non-suicidal self-interest behavior in children and adults with intellectual disability, and what we can do to help address those behaviors. Cultural and spiritual beliefs. We encounter this from time to time. Understanding how those impact our condition is very important for the resident, as well as the family and the system. And then providing social support, connecting them with the right medical team, and then hopefully ensuring a good environment and community for this person to thrive. Ultimately, I'm not trying to take a patient to be the primary service. I'm trying to be the liaison to connect people from point A to point B, so I can help support the internist if they need help, or help support the pediatrician if they need help with this chronic condition. I'm going to briefly talk about education, and I don't want to take up the entire conference for you guys. And then I'll let you guys ask me any additional questions. So I spoke a lot about experiential care, and so this is my pyramid of education. And I think nationally, we're trying to institute a standardized curriculum for all the residency programs in Med-Peds for transitions of care. And so we have a general transition lecture in our institution that we give to residents. We have a transition case database that we're building to help educate residents on specific cases or conditions that they encounter. And they get experiential care through the consult service, whether it's inpatient or outpatient. But I think ultimately, like at the peak, what includes is a place that has the ability to provide some scholarship, didactics, and experiential care for that learner population. Didactic wise, we have morning reports that the residents will do. Usually we'll have a couple in the year focus on transitions of care. Often those are patients with disabilities. We have grand rounds that I make the grand round schedule at University of Chicago, so I purposely make the grand round schedule to include patients with disabilities. This year, one of our grand round speakers is Erin Hickey, and she's going to talk about disability through the lifespan. That's our grand rounds topic. And then we have academic half days, and so that's 4 hours dedicated to interactive training on transition topics and disabilities. Actually, Zoe Sheets is one of the residents who's leading the academic half day, as well as Rahul Dadwani. And so we have that scheduled for, I think it was mid-July, July or August. I forget the date right now. I looked at it yesterday and it's beyond me now. For residents to sit down with me, and we go through the various mechanisms that we can support the patients through the system. And at the very end, we'll have, I'm going to try to have a patient panel, at least a patient and their caregiver come in and talk about their experience going through this and what we could do better as a medical system and a team, and what they wish they could have done. And then briefly about scholarship. We're working with residents here at University of Chicago to advance healthcare transitions. In the past, I've had medical students and residents that we've worked with. These are 2 articles that we had published, one in 2024 and one in 2023, regarding healthcare transitions from a cross-sectional survey that they did. And then looked at the attitudes and behaviors of the the residents in the various residency programs across the country, and what factors we could do to improve transitions there. And having transition champions is a very helpful thing to help to push forward healthcare transitions in those various places. That is everything I have. I will stop sharing, and I'm more than happy to answer any additional questions that you guys have. I hope I wasn't speaking too fast.
This is Mike. Thank you so much for your presentation. Really wonderful work, and certainly gives us a lot of ideas on what we need to do here, and certainly what we have to do across the country. I know there's places where it's just not even talked about, so they're really starting ground zero. So I'm going to open it up for everybody to ask questions. Yeah. Anybody have any questions for Dr. Abou Baker? So I'll ask another question then. So in terms of the residents and the buy-in and the training that you have, I know you talked about an academic 4-hour slot, which I know personally has struggled just to even get a little bit of time, and it sounds like you have a half day to do that. So again, was that something you've had to kind of gradually build on and get the buy-in of a residency director?
Yes, so it's very important to have buy-in. Now, I will say, I was the program director,
Sure.
so I was the program director for 2 years, and the previous program director and I were extremely close, and her and I helped advance and develop the program here, the Pathways program. So yes, it's important to have buy-in. I think the 4 hours is definitely not enough to gauge everything. But it's something that is helpful, that I can give them a bolus of knowledge in a very short period of time, that they can early on in the academic year, that they can carry through the rest of the year. And then as we do our monthly conferences, they have like a monthly just noon conference where they learn about, you know, hypertension or whatnot. We try to incorporate things, be it about disability and transitions of care. We have at least one monthly conference. I didn't talk about that on disability, and this this is something that, you know, we try to keep in mind for the residents when we create the academic calendar. I think I had the benefit of, I control their academic calendar. So like there's a method to my madness, if you will. And so I've purposefully planned it out so that there's incorporation of transition of care, caring for patients with chronic conditions and disabilities in there. And I try to make sure when grand rounds is being scheduled that at least we have one a year that is directly focused on this. If more the merrier. But it all depends on what external forces are asking for grand rounds, and how we're distributing throughout the year. But at least one every year is focused on disabilities.
And then the second burning question, sorry to hog the time here, but the second one is really how you work with your disability organizations. And I know we often engage depending on the disability type. So like I work with a deaf organization for my deaf patients. I target physical disabilities, IDD. There's another group that I tend to target. How does that work? I know you're doing more of a consult opt-in. And so how do you make those connections? Do you just tell them I would recommend this organization? How do you build those relationships too?
Great question. So I have a robust list of case managers and social workers that help with this. So I have 2 social workers, and depending on the insurance, I can get case management involved from the insurance that can help support this. I have connections through the state, and a lot of colleagues around for our regional healthcare collaborative. So it's us, it's Northwestern, it's Loyola, it's University of Illinois, Chicago. So we're all sharing our knowledge and resources. And then I know we plugged it in the very beginning, our Illinois Healthcare Transitions Conference. We every year we host that. This year it's in Springfield in late October. There we actually have as many of these organizations try to come there and present, so that they're face forward for providers to learn about the organizations, but also for we open up to people, to patients, that they can come and learn about what organizations, whether it be from the education standpoint, whether it be from rehabilitation standpoint, or you know, something else that can help provide support for them as they age through the years. So that conference is a really good like touch point for people in our system, at least, to get a lot of information very quickly. It's arguably overwhelming amounts of information that you squeeze in 2 days, but like it gets them their foot in the door, if you will.
We have time for maybe 1 or 2 more questions. Anybody else have questions?
What do you think is the recognition and support of your leadership and the leadership of the hospital and the health system for these types of services?
You know, I think they recognize it's important, but they're also pulled in a lot of different directions in terms of health initiatives for the healthcare system. So I do have a very small piece of the pie that I appreciate, and I'm always advocating for more funding, more social work, more help. I don't think it's on the top of the priority list, to be frank, but they aren't explicitly ignoring it either. So I would love to have more attention, but I think they're doing their best with the number of different directions they're being pulled. But I always do think there's room for improvement.
Okay. And I'm sorry. And are there any, or do you think there are room for supplemental types of activities or programs, camps, or whatever else to help facilitate these transitions and processes more in a more bolus or systematic way?
Yes, so specific conditions have significantly more funding
Right.
that can help lead this forward. And the big example I'm going to give you is oncology. Okay, oncology has almost an unlimited amount of money. And we're building like a very, 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 very big oncology center here at University of Chicago that's going to open in a couple of years. And so when looking at the transitions and adolescent young adult cancers and survivorship, there's a lot of importance in funding geared towards that very specific condition entity. There is less so when I look at patients with physical disabilities, maybe people that use wheelchairs, people with intellectual disabilities. There is not as much specific condition funding. So that's where usually I will gear my time towards trying to support the conditions and patients that have less available funding and support from either the insurance or system-wide. But yeah, that is 100% true, and I think that's true across probably the country. But that is something that happens here too.
Thank you.
Okay, we're out of time. So again, thank you so much for joining us. And this will be recorded. We're going to share. I know a number of medical students were not able to attend today. So we'll certainly share it. And I will certainly be in touch. This won't be the last time you'll hear from me. We'll continue on. And I know I'm really very interested, possibly having where we can have students come both ways to learn. I know we have a number of students here very interested in disability health, and would love to do an external rotation there. Thank you everybody for joining, and we'll see you next time. Bye.